And I want to go on to Dr. Zola N'Dandu. He's another amazing vascular specialist out of New Orleans. One of our P.A.D warriors. He was able to save her foot when more than a dozen doctors had told her it couldn't be done, it shouldn't be done. And Dr. N'Dandu not only took her on as a patient, but he ended up even having her transferred to yet another hospital to bring her in. So thank you, Dr. N'Dandu, from the bottom of our hearts for helping to save one of our fellow P.A.D warriors. And we're going to be talking right now about another Hail Mary save for people. You know, let's say a pedal loop revascularization doesn't work. What's next?
Thank you very much for having me this afternoon. I appreciate sharing the panel with some incredible colleagues all over the country, and for all the patients and family members that are here to join us. So I'm gonna share my screen. If this would allow me, give me 1 second.
Perfect.
Okay, can you see it very well?
We can see.
Okay, very good. So today I'm going to talk about deep venous arterialization as an option when we get to the point of quote unquote saying no option. And going to this, it's very nice actually that I'm going after my very good friend and colleague, Dr. Roundback, who talked about revascularizing patient. We talked about plantar loop reconstruction. Dr. Mike Cumming talked earlier about surgical intervention. The combination of the two are things that we can do. But unfortunately, it gets to a point, especially on diabetic patients, where we can no longer do that, either because there's so much, the vessels have so much calcium that we cannot use balloons and stents to open them, or surgically, they're so calcified that we don't even have targets, or we cannot even sew a bypass to that. And so at times, we can offer this option, very difficult, but definitely possible. So deep venous arterialization, the idea is to connect the remaining arteries that are there to veins with the ultimate goal of delivering blood to the foot. And who are the patients that could potentially qualify for this therapy? Usually these are patients that we've done multiple interventions on, either stents, balloons, we've done atherectomy and things like that, and they've failed, unfortunately, or patients that have had bypass in the past, no longer can have bypass, or no longer have any targets, meaning perhaps they could have a bypass, but there's no way you can attach that bypass to, or we don't have any what we call conduit. But most importantly, as mentioned earlier by many other panelists, is it has to be done early enough, meaning you cannot have a patient that has a foot that's so infected that the foot is far gone. So the idea of addressing and meeting patients early becomes extremely, extremely important, because as we're running out of options, we can still come up with things, unlike when the infection is so far advanced, we might be limited. And really here, by the time we're providing this option, the reality is we're desperate, because otherwise we would have done what all my colleagues have talked about: the pedal loop reconstruction, the bypass, the angioplasty, the stent, the atherectomy. But by the time we get to this point, is because really we don't have anything else. And this can be done, what I mentioned about percutaneously, meaning can be done with from beginning to end with small holes using balloons and stents and some specialized equipment, or it can be done surgically. We have some colleagues that can do that, or it can be done in combination with stents and surgical intervention combined. And that's what goes along earlier with some of the colleagues also mentioned about working together collaboratively to be able to accomplish this. Really, when you work on this in the silo by yourself, it's not possible. And the idea is when you connect the artery to the vein, that vein can then deliver blood to the foot, sort of confuse the vein, because the vein was meant to take blood from a foot back to the heart. But here we sacrifice at least one to reverse that aspect, to deliver blood to the foot, to improve the perfusion to the foot, and hopefully be able to save a wound. There's a company called Limflow. They've been very aggressive and instrumental, and really in the forefront of improving this technique, where they've developed a specialized dedicated stent, specialized equipment that can allow us to cross from artery to vein, and some specialized equipment to destroy some of the valves in the vein so we can adequately deliver blood to the foot. And here I have a particular example of a gentleman who came to us who had a history of high blood pressure and diabetes and high cholesterol, had diabetes for more than 20 years, was on dialysis. By the time I met him, he had already one intervention, unfortunately, had failed. What I didn't realize but also by the time we met him, he had been offered to be amputated 5 times, including one time he was on a schedule. He just didn't show up for the amputation. And so we took him on, and our evaluation, what he showed us was the arteries from the hip all the way down to his knee were okay, which is not an uncommon thing for a lot of our patients, especially people that have been diabetic for a long time. His issues were the artery here is the level of the knee, is below the knee. So here we have 2 arteries that are functioning fairly well, but the artery going towards the heel, as Dr. Roundback mentioned, we need to get blood flow to the wound. The one artery that's going directly to that wound is completely blocked. And here I just have a picture of an ultrasound and x-rays to show you how much calcium there is. This right here is a bone, and that right there is an artery. Normally, these are things that we don't see. But when it gets to this point, because it's so calcified, and here I have a CAT scan showing how much calcium you have. This is his bone. Right here is just calcium in the artery. It shouldn't be that way. So by the time the artery gets to this point, extremely difficult to open. So what we did in collaboration, knowing our limitations, we brought in our radiology technicians. They helped us to obtain access. Here is an ultrasound at the bottom of the foot. We played around, we did some drawings, so we knew we're gonna get in somewhere around here. And the idea, if we get into the vein at this point, we're gonna travel in the direction of the vein and make a connection with the artery. And that's what we did. You can see the calcium within the artery right here. We're not supposed to see that normally. This is the leg, this is the bone in the leg. And we have a snare into the vein that we put in from the foot area that I just showed you. We put a snare in the artery, we made a connection. We're able to pull that together. And so we can create a connection between the artery and the vein. Then afterwards, we went ahead and used balloons. So here you can see this balloon is inflated. We're opening the balloon, trying to push that plaque on the side, as Kim mentioned earlier. The vein is wide open, so you can see the balloon open very quickly. The artery is taking some time, and where it's pinched, that's the hole between the artery and the vein. And this artery abruptly ended around here, so we're gonna make a connection so the blood, instead of stopping right there, is gonna go into this vein and hopefully deliver blood to the foot. And that's what we did. And so this is our final result. Now we're getting blood to the foot. And what we did was, we can see that prior to our procedure, we were getting some blood, my mouse. Oh yeah, we're getting some blood to the heel, but it took quite a bit of time to get there. Almost 18 seconds, that's all in blue. By the time we finished the procedure, now it's red. So we're able to get it there in about 2 seconds or so. We're able to improve the time it takes for blood to get there and the volume. As you can see, with a multidisciplinary approach, meaning it's us in cardiology, it's our podiatrist, it's our wound care nurse, it's our home health nurse, it's the patient, it's the family who are supporting the patient, who bring him to his appointment, that we're able to get this wound to heal. And this patient, as I mentioned earlier, was offered to be amputated 5 times prior to meeting us. This is another young lady who came to see us, who also had similar problem, had multiple interventions in the past, and eventually ended up having what we call a TMA, where all the toes were amputated. And Dr. Ronberg brought out something very, very important, that when that amputation was done, the skin flap from the bottom is what's looped up at the top here that becomes your suture line. Now, the top of the foot has blood flow, but the bottom does not. So when you bring that skin from below without any blood flow, you wrap it around here, it's not going to heal. And that's exactly what happened to this young lady. So the artery was extremely calcified, and similarly, we could not open this artery. As you can see, the wound after the amputation is deteriorating, and here we are facing a situation that she could potentially be amputated. So we did the same thing. Here we have a long balloon right here within the vein. We have one in the artery. We made sure, as somebody mentioned, image-guided intervention, meaning I don't want to just go by my eyes, because perhaps I will be wrong. But instead, with the intravascular ultrasound, we can get a 360 evaluation of these arteries and veins. So now, this artery that I would have easily thought was perhaps a small artery, turned out to be actually it's a very big artery. And same thing for the vein as well. And here we use the device that allows us to cross from artery into vein by puncturing that balloon, so we have something to visualize. And we did the same thing. Afterwards, this is what we have. We're able to get blood flow. And most importantly, if you look at this image right here, the same foot that we didn't see any blood flow at the bottom, now we can see some blood flow. So earlier what we had was just the top. Now we have the bottom as well. And the patient went on to heal in a couple months, also with us working together as a team. It wasn't just the revascularization that helped, but it was the wound care, it was the antibiotics, it was the endocrinologist, it was a family member that brought the patient weekly to a wound care visit to be able to achieve this. And very lastly, it's another gentleman, and talk about the reason why we're doing this meeting virtually is probably because of the pandemic. Otherwise, we would have been together in one room celebrating somewhere in San Francisco, who knows where. This is a gentleman who came to us in the beginning of the pandemic. I saw this gentleman, we're going to bring him for his procedure. Unfortunately, got sick, had COVID-19, extremely sick, multiple organs gave him trouble. And you can see with this kind of infection, we couldn't do anything. So he had an emergent amputation to control the infection. Then after things were stabilized, then we got involved. And I just want to show you here by X-ray, you can see this is his foot. Look at the bottom of the foot. His arteries are so calcified, not much different than the bones. If you look at his toes, technically you're only supposed to see these bones, but instead you see what looks like almost like a little tiny bones in between. These are just arteries that are so calcified. And unfortunately, our traditional way of opening the arteries did not work as well. We managed, what you see in white are his arteries, and we had to use what we call CO2 angiography because his kidney function was not very good, but we still wanted to make sure we could preserve his kidney function while trying to preserve his limbs. So in here, you can see in white is what's there. In red, it's what's missing. So this is the artery that goes on top of the foot. It has some blockages, the one in the middle and the one that goes towards the heel to make that connection that Dr. Ronback described as the plantar loop. Here you can see the one that goes to the front. What's in red are 100% blockages. And here as well, and you can see the entire bottom of the foot is almost like an orphan where there's no blood flow. And you can see the wound deteriorating even after we opened those initial two arteries. And eventually we brought him in. We did that procedure where we connect the artery to the vein. We used the one artery that was blocked 100% in the back here. And then you can see now we have a loop. We have a connection where the entire foot is getting blood flow. And this is what happened. Aggressive wound care, working together with our colleagues in cardiology, endocrinology, wound care nurse, home health, and the patient family. This patient never missed an appointment, always came, and you can see the foot heal. So what we've learned over time is obviously patient selection is extremely important. It might not be appropriate for every patient. Getting patients early, extremely important. So that way we don't have a foot that's too infected where we can no longer do anything. As that's what I mentioned by requiring a salvageable foot. When it comes to wound care, as I mentioned, not just myself, but multiple other colleagues, it takes a village to do this. Many of us have to work together to be able to achieve this. Minor amputation can be done, and timing of debridement extremely important as well. As you can see in this graph at the bottom, even after we do the procedure, because here we are confusing veins to do what arteries are supposed to do. So tricking those veins takes some time to build up to be able to do something effective. So it takes approximately 4 or so weeks to get to that point. So if you come in with a wound that's so far advanced, you don't have 4 weeks to wait. By then, unfortunately, it's not going to succeed. So coming early becomes important. So that way we have this window to wait for things to get to a point where we can take care of you. And here you can see the graph, as I mentioned earlier, it takes a team. So you talk about endocrinologists, infectious disease, podiatrists, revascularization specialists, and it does not matter. As many providers have mentioned earlier, what it takes is people that are passionate to do this, whether in my case, I happen to be a cardiologist, or an interventional radiologist, or a vascular surgeon, is really all of us working together to provide what we think is best for our patients. And obviously, we can always re-intervene if need to, but this is something I wanted to share to know that even when we get to the point of no options, perhaps we can have option. And this really to share with you some of the things that we're doing. So hopefully, we don't have to watch our patients hope for themselves, but we, along with them, can hope them to come up with an option to save limbs and ultimately save lives. Thank you very much for the attention. And if you have any questions, please.
Yeah, and the reason I thank you so much, Dr. N'Dandu, and the reason I bring this up, this isn't going to be right for every single person, but I want to arm every single one of our PAD warriors with all of the options that are available to prevent amputation. It doesn't mean that you can get away from the amputation. It's really about you choosing the right doctor that has this strong armamentarium of just in case, just in case, just in case, that they can exhaust all efforts, or at least is willing to give you up to someone who can exhaust all efforts to at least give you the best chance at saving your limb. Only a small percentage of folks with peripheral artery disease end up with this critical limb ischemia or critical limb threatening ischemia. But you don't even want to get to that point. So it's really important to find someone who has these advanced skills so that, and make sure that you're on top of it. Each of these doctors has, thousands of PAD warriors that they have to deal with on a daily basis. It's really going to be up to you at home in between appointments to make sure you're not a toe step away from amputation, that you're staying atop of your foot care, and that you're making sure that if there's any break in your skin, you're getting into the doctor as soon as possible to make sure that you're not going to get to a point where you do need a deep vein arterialization. Right, Dr. N'Dandu? You mentioned earlier the better.
That is very correct. The earlier we do this, the better, because obviously we know when wounds are not as big, you don't have as much of ischemic demand. So you don't need as much. When the wounds are bigger, it's very difficult. And then we know the bigger the wound, the more expensive it is, the more hospitalization, the great likelihood of dying, and the higher likelihood of getting amputated. So the earlier, the better. And so that's why the early referral, the early evaluation, the early intervention, extremely important.
Is this something, is the DVA procedure something that seems to be catching on more and more, or do you find that there are some doctors that are completely and adamantly opposed to it? And if so, why?
Well, no, that's an excellent question. So I think with DVA is it's still, even though it's an old procedure, I was not utilized for a very long time. So in a sense, it's in its infancy. We're starting from zero. We don't have anything to compare to. Obviously, we do have some clinical trials happening right now with Limflow with the Promise 2. So that's going to give us more ideas as to how to apply this, patient selection, who can we do this on, and to help patients. But with the crisis that we currently have, especially here in the US and worldwide, with diabetes and people living longer, these are issues that we're going to be dealing with for a long time. So if we don't get good at doing DVA now, I think we're going to be in trouble. So we're going to have to get very good at doing it. But somebody mentioned earlier, addressing lifestyle and risk factor becomes extremely important so we don't get to this point. It's only 1 to 2% of patients with peripheral artery disease who end up with chronic limb-threatening ischemia or CLI. But within that percentage of people, about 20% of them are no option patients. So if we work hard to minimize those risk factors, hopefully we don't get there. But for those people that get there, if you don't offer them anything, unfortunately, they're going to be amputated. And we know very well, once people get amputated, the mortality goes up. So I think DVA is here to stay based on what we currently have. We just have to get really good at it, to do it well, to select who's going to benefit the most. And we're going to keep refining the procedure to help out, to save lives.
Fantastic.
So, Kim, if I can jump in,
yes,
I just
please.
wanted to ask Zola a couple questions. So thanks, Dr. N'Dandu. I mean, you've been like trailblazer in this field, and I really appreciate what you do for your patients. Like you said, this particular procedure is not meant for everyone.
That's correct.
You have to select those patients very, very carefully. Unfortunately, as far as I know, there are only few selected operators in the country who I would trust to send my patients for DVA. And you happen to be one of them, but you are in a far off state from where I am.
Yes.
So if I have to refer a patient to you, how does that work? Because a lot of the times we are challenged by the insurance companies, and this is not a cheap procedure. It's a fairly expensive intervention.
Yeah.
So how do you handle that?
Thank you very much. So I'm here in Louisiana, in New Orleans. I've had patients come from Florida all the way here. But you're right, it's not easy, it's expensive, it's very difficult. But the good thing is very much like what you and I are doing right now. We've had a chance to collaborate with many people around the country. So if something came up, and this, for instance, you reached out to me, I can always find somebody else who also does the same thing, hopefully near you, to make it easier for the patient and their family. They don't have to travel as far. Within the Promise 2 trial that I'm participating, there are multiple colleagues, even though it's only 18 or 20 sites, but perhaps we can find a place that's closer for that patient and that family to go to be able to go there and have the care that they need. So if need be, it can be a phone call, Kim can always reach out, and we can reach out to many other colleagues around the country trying to help out. Because I agree, it's not easy, and having to travel is not easy either. So we need to find a way to connect to help our patient. Today, I had another case, not a DVA. I needed some help, and I've got advice from colleagues in Japan, in England, in Spain, all over the US. So next week, when I take out this patient, I'm going to have the help that I needed, but it came from all over the place. And so we'll do the same thing for anyone that needs a DVA.
Thank you.
Fantastic. Thank you so much, Dr. N'Dandu.